So I use CT angiogram to prepare the patients for renal artery denervation. Before they have their CT angiogram, they've already had all their biochemistry done. So we've excluded cons and pheochromocytoma on biochemistry. But it's also useful to have a CT to look at the adrenals. So in this patient, the adrenals look normal. There are no lumps or bumps in the adrenals, so I'm quite happy there isn't a mass in either of the adrenals. If there were a mass in the adrenals, I'd bring the patient back for a 3-phase CT of their adrenals. I measure each kidney and make sure that the kidneys are within normal length, so that if there is any calcified atheroma at the renal ostia, I can be sure that there isn't a significant renal artery stenosis. Then I bring up each renal artery in turn in MPR and measure the diameter. The artery has to be at least 4 millimeters in diameter in order to do the RDN procedure, because otherwise the temperature build-up at the tip of the catheter is too rapid and the generator will cut out. So this artery is 5.8 millimeters in diameter, and the other thing we need to check is the length of the artery. We need to do 5 burns in a helix, 5 millimeters apart, and therefore we need an artery that's at least 2.5 centimeters from ostium to the first division. And in this case you can see that's the renal ostium, that's where the artery divides, and it measures 37 millimeters, which is fine. So we keep going down, you can see that this right kidney has a small accessory renal artery coming off at the 11 o'clock position from the aorta, and that artery is, just eyeballing it, not wide enough. It's only 3 millimeters at the renal ostium. Doesn't exclude this patient from having the procedure done. The dominant artery is large enough.